Well, hello, everybody, and welcome. This is Erica Spicer Mason with Becker's Healthcare, and I'm so thrilled that you've all joined us for today's webinar on the shift to outpatient cardiology. But before we get started, I wanted to walk us all through just a few quick housekeeping items. First, we'll start today's session with a presentation, a discussion, and we will have time at the end of the hour for a question and answer session. And audience members, please be sure to submit any questions that you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and it will be available after the event. And you can use the same link that you used to log into this webinar to access that recording. And finally, if at any time you have issues with audio or visuals, just try refreshing your browser, and you can also submit technical questions into that same Q&A box. We're here to help. So without further ado, I'd love to welcome our three fantastic speakers that we have with us today. I'm going to ask that each of them shares just a little bit about themselves, what brings them to healthcare, what brings them to the webinar today, just to give folks on the line a sense of the perspectives that you're bringing to the conversation. Kristen, do you want to get us started with introductions?
Sure. Well, thank you for having me today, and good afternoon or good morning, wherever you may be today. But my name is Kristen Richards, and I am the Vice President of Ambulatory Care for Cardiovascular Logistics. I have oversight of all of our ASCs and OBLs across the country. So I do a lot of traveling, and so it's a huge passion and focus of mine. But I have spent, I'm gonna age myself here a little bit, well over 30 years in the healthcare space. Kind of started my career with Banner Health and worked with them for most of my career before moving on into other areas, working with Philips as more of a consultant type, spending time with over 400 cardiovascular programs in the country. And now my focus has been predominantly the ASC space and this growing space. And it's exciting opportunity for us to really provide greater access at a lower cost for our patients. So thanks for having me.
Oh, it's great to have you, Kristen, and great to know that you're bringing so many perspectives from all across the country to what we'll be talking about today. Dr. Reiner, would you like to tell us about yourself next?
Thank you, Erica. Yes, I'm a cardiologist by original training and background. Practiced in academics as well as in private practice. Been a program director in academic, the director of a department of cardiology, and in private practice ran a single specialty group that covered several states, including rural healthcare settings. I subsequently stepped out of that role as direct patient care, but do management consulting now, and in the process have had the privilege and pleasure of working across the United States for over 30 years. Strategy, business development, and leadership development associated with the strategy and recommendations that we make from many, many organizations around the country. Good to be with all of you today.
Oh, great to have you with us, Dr. Reiner, especially having this clinical perspective on the call today, I think is going to be really important for the conversation. So thank you for the time. And last but not least, Derek, tell us about yourself.
Thanks, Erica. Yep. Derek Hidbase. I'm the Chief Commercial Officer for MedHQ. We provide administrative services for outpatient healthcare, as well as helping develop strategy for health systems and providers looking to embark on that journey. Really excited to be here talking about a very important topic in healthcare today. I appreciate these colleagues coming along and joining as well. My background originally started working in physician-owned hospital development, specifically around cardiovascular care. So I've been working in the space. We all know when that moratorium went in place, so a long time now. It was an exciting part of my career, and watching providers develop that and learning about focus in that care in the acute care setting, and now seeing it move to the outpatient setting is very, very interesting. After that, I started a revenue cycle management company, ran that for about 10 years until being acquired by MedHQ and joining the family here, and excited to see the next stage in cardiovascular care go forward. And I think this topic is a huge piece of that. So I'm excited to be here. Thank you.
Yeah, thank you so much, Derek. And excited to dig a little bit deeper into something you just touched on. You noted that shift, this migration that we're seeing of cardiology into outpatient settings. So Derek, I'd love to start with you, if you don't mind. I know you have this great macro level perspective in the work that you do with your organization. So I'm wondering if you could just give our audience a sense of what's fueling the migration of these cardio procedures to the outpatient and ASC setting, and why do you think this has gained such momentum at this point?
Sure, and I think it's multifactorial, of course, and you say I have a macro view. Some might say I have a pretty myopic view, being in the seat on the business side of healthcare, right? I grew up the son of a cardiothoracic surgeon, so I think I have some vision into how physicians think. I worked in developing physician-owned hospitals and believed in that model, but at the end of the day, I went to business school and I focus on the reimbursement side, the regulation side, what is Medicare doing to drive this? And I think from my point of view, and I'm really interested in Dr. Reiner's point of view of this as well, because this is going to be completely different. I look at, what's the federal government doing that's making this of interest and making this accelerate, perhaps. So we're starting to see, and we really are at a place where most procedures in the cath lab can be done in an ASC and be reimbursed by federal programs. That was not the case 10 years ago. There was a relatively slow shift to this for a while, and over the last 5 to 6 years, we've just started seeing more and more things be approved in ASCs. And for the final rule for next year, we're fully expecting, if it hasn't been confirmed already, that we can do chronic total occlusions in a cath lab, which is something they always said, no, we're not going to do those there. And we're just seeing all those things change. And then, of course, historically, you've seen that cardiologists could not participate in the tech fee side of reimbursement because of these rules. Now you're seeing that change, and you're seeing the opportunity to participate in that place when we all know that physician reimbursement has changed dramatically over the last 20 years as well. So there's financial reasons for it. Dr. Reiner is going to expound the healthcare reasons for it, and I would never pretend to understand those as well as a cardiologist would. So I'm just going to stay out of that and not make myself look dumb. So from a financial perspective, from a legality perspective, and all those things, so many other specialists have been able to build and operate ASCs and have more control over how their patients are cared for. And going back to my time in physician-owned hospital development, that was the same incentive back then. So I think there are a lot of moving pieces, but from my perspective, the biggest one making it possible, not necessarily necessary, but possible, is that payers are paying for these procedures, not patients things now. And it helps long-term expenses in healthcare just as much as it helps other things as well. So from a business perspective, I think that's what's driving a lot of this, but very interested in hearing my colleagues' thoughts here as well.
Mm-hmm. Yeah, Dr. Reiner, go ahead. I just want to, go ahead, Dr. Reiner. I'll weigh in after that.
That's okay. That's okay. Well, I'll pick up where Derek left off. I might take a little bit stronger stance, as someone who's sat in the big academic centers and the community hospital centers, and in the different environments, urban, rural. There are so many reasons why I think almost at this point in time, the strategy to move to this new environment, not in total, and I'll come back to that, but to take advantage of a change of place for sundry reasons, not the least of which, that if you look at the preliminary data, and if you talk to patients who've had procedures, they're very happy with it. Let me enunciate on some of those just a little bit more. The number one reason that the ambulatory surgical center is becoming a nidus of operation for cardiovascular specialists is it can be done. The technology has evolved over the years to the point that it can be safely applied in an environment other than the inpatient setting, with the caveat, and I'll come back several times to this, that we've got to address some safety concerns and safety issues, but patients like it. And it's convenient for them. There's not a person probably on this call that doesn't know that hospitals are complex beasts. And I don't say that derogatorily, having fondly worked in them for many, many years and still do. The complexity poses challenges for staff as well as for patients. Continuity of care within the context of even the four walls of the hospital become challenging sometimes. So the environment itself lends itself to a more pleasant environment, a more feeling of secure environment in some settings for patients that have difficulty navigating complexity. I'm here to tell you rural situations certainly are that way. People don't like to come to the big city from the rural areas. In the older population, the complexity of the big organization. So it's a patient satisfier if, with a capital I, if it is done correctly. The other thing that I'll throw out, and I'm sure we'll talk about it more, is it is a more cost-efficient environment in many ways, both for the providers, the physicians, the staff working in it, as well as from a patient's vantage point and from a payer's vantage point. We'll come back. There are challenges to that, and I'm probably just caused agita to a bunch of folks that are listening on here, but that's the facts that are out there. And so, it is to say that, this trend is going to go away. I smile when people say that because I think it's only going to grow. And it is not about where you can do it, because, life is a journey and life evolves and we do it differently in different places. It's like putting your finger in the dike and think that you're going to stop this. So my recommendations, in short, and we'll come back to it again as well, let's learn to deal with the trend. If you're a hospital, you may look at this as a challenge. If you're a medical group that's doing things and you're uncomfortable and don't have access to it and so forth, you look at it as a challenge. Some medical groups may look at it as an opportunity, and we'll talk about those opportunities in greater depth. But I want to spend a few minutes on the major concern. If you're going to move into this environment, and I would say the same thing if you're going to do something in the inpatient environment, do it correctly, for the right reason, by the right people, so that you have good outcomes. As a physician, my obligation, a fiduciary obligation, is to take the patient's concerns first and put them in the right place to obtain the care that they think they need and that I agree with that they need. And I think the infrastructure is a big piece of doing it successfully in the ambulatory surgical center. I've just mentioned how more convenient, less complexity, but anchor it the same way that you would anchor complex things in the hospital and do the right things in this environment. You've got to be looking at patient selection in that environment carefully. We come to this several times, I'm sure, but there is, we do surgery on the battlefield robotically. My comment would be anchor this with the same concern over safety and quality. Measure it, monitor it. The American College of Cardiology has put together a database that looks now at ambulatory surgical outcomes. I parenthetically was one of the original founders of the initial NCDR. I think those types of anchoring give patients a comfort. They probably don't know they exist in large, but every physician should know, and every team of nurses and executives who have an affiliated surgical center or anticipate should also take that as the MO that will anchor these types of activities. Succinct answer, they're here to stay. They're only going to grow. And I think that I would counsel, staff and strategists among our hospital and health system colleagues to spend time looking at it realistically to make sure that they're part of that trend.
Yeah, Dr. Reiner, Derek, you've both touched on really important buckets here. There's the financial piece that, of course, is going to be really important for organizations in the current financial environment for health systems and other healthcare organizations. You've touched even on patient satisfaction and how the outpatient setting can be a big satisfier for patients, drives efficiency, so on and so forth. So I think these are all really important points to raise. Kristen, just wanted to check in with you before we go back to Dr. Reiner, because I do want to dig into some of these safety and operational concerns that you've raised, Dr. Reiner, but Kristen wanted to give you the chance to weigh in if you had anything to add to this initial question.
No, I think he's absolutely right. I mean, spot on. And I always tell our ASC, the leadership, it's all about setting up the infrastructure so that you are ensuring that it's the right patient for the right procedure at the right facility. And doing that, you have to set up an infrastructure that is very patient focused, quality driven. You are standardizing protocols, you're standardizing order sets, you're optimizing evidence-based medicine. Boy, there's some clear data written from SCI, from the ACC on what you should and should not do in this space. And they're recommendations, but it should be foundationally how you're operationalizing your ASC. So this is a critical component when you're setting up your ASC, that you're starting out the gate right. And so he said it well. I couldn't say it any better.
I go back to what I said in the beginning. The right patient for the right reason by the right person. A lot of groups have 5, 6, 7 people who do interventional, and now that we're going to be doing more on the electrophysiological side. Patient selection is critical. There should be no one on this call to think that in any way am I personally advocating everything to be done in the outpatient ambulatory surgical center. That's crazy. There are bona fide, cogent reasons why certain patients should never even have the message brought in front of them that you might consider this. And likewise, people's skill base might preclude them from doing certain things in an ambulatory surgical center. But just as Kristen said, the infrastructure, how you accommodate the concerns and make sure that you're anchored properly, will give the patient comfort, your staff comfort, and in general, the people that you're going to be working with comfort as well. So,
Yeah. And Dr. Reiner, just a very brief follow-up to that. Is there a specific procedure or type of patient, or just anything that you'd really like to highlight for the audience as something that should be a safety consideration or kind of a red flag for patients that they're considering for having a procedure done in the outpatient setting?
Well, this is where your clinical judgment will come in. I think in large part, the physician who's seeing the patient and considering having a particular procedure done, which can be done if necessary in the ambulatory surgical center, should put the clinical situation in context. Elderly people with multiple comorbidities, people who would be unstable in the best of hands, or if they became unstable, would be critically more difficult to handle. So I think you have to be selective. You have to be able to say that this person would be better off in the hospital to have this procedure done. The magnitude of what you think you're undertaking in the individual with all the other aspects are absolutely critical, critical. So it's clinical judgment, and that's it's clinical judgment and the right expertise to be applied to that. And we're doing single vessel angioplasty. There can be times that I think you'll be doing two vessels. You might even at some point be 3 vessels. In the right hands, in the right patient. There may be somebody only needs 1 vessel, and you'll say, no way, no how should we do this in there? We should do this in the hospital because this person's 95 years old and has had heart failure, and in fact, probably in a little heart failure. Don't even think about it. Just, why risk it in that situation? We'll come back, but that's part of why you want to have, and as I say, a health system should have relationships with people and vice versa. It's a team. It's a therapeutic part that will be part and parcel of every health system in that regard.
Yeah, really important considerations. Thank you so much, Dr. Reiner. And Kristen, I want to come back to something that you had already started to touch on, and that's the idea that ASCs need to ensure that they have the appropriate infrastructure to support outpatient cardiology patients. So from your perspective, what are some of the biggest challenges that you see facilities face around staffing, equipment, workflows, and really how do you recommend leaders prepare to really ensure that they can scale successfully?
Yeah, there's no doubt the cardiovascular ASC space is different than any other ASC. No matter how you slice or dice that, it's different. The equipment, there is tremendous capital expenditure that happens in this space. And the reason why is because the equipment that they utilize is exactly what they utilize in the hospital. So you could build out one room and it'd be over $1 million because it's big iron, it's all the imaging technology. You still need that. You need that to provide the services. So that is a very important understanding from the ASC when you're developing a CV ASC, that you're putting a pro forma together, that not only do you understand the cost, but that you have the alignment from your physicians or your JV partner with hospitals and the physicians, that you've set your pro forma up, you understand your volumes, you have good diverse case mix of volumes to be financially sustainable. Those are critical, right? Critical steps, and a huge challenge. That's a barrier. Just cost in general for a CV ASC is substantial. Staffing, well, we're seeing a staffing shortage in healthcare all across the country, right? There's no exception here in the cardiovascular space. These are highly skilled, highly trained individuals. And you want them in your ASC, you want them at the table with your physician so that you're providing the highest quality care with a very proficient team. That's a challenge right now because hospitals are struggling to fill these roles in the cath lab. So they're providing sign-on bonuses, retention bonuses, which makes it challenging in the ASC space to fill those roles. Then you couple that with the exciting potential of the proposed CMS expansion of the covered procedure list, which now adds cardiac ablations, which is so exciting to expand into this space. There's a whole nother specialty of EP folks that most ASCs, CV ASCs don't have at the bedside. So this is a challenge. It's a real challenge for folks that they're going to have to understand that, prepare for it, understand what you need to put into place to make sure, again, that you're providing the highest quality care at the lowest cost in your facility. And lastly, we've already talked a little bit about the workflow. It's critical. It's essential to the success, right? That you're developing a very robust quality program. You're developing a robust PAT process by which patients come in your doors so that you have a patient exclusion or criteria for those patients. And then your staff is empowered to, when they're reviewing those and they're calling the patient, that they may pick up the phone and call the doctor and go, you know what? Mrs. Johnson probably isn't the right patient to come here. And let me tell you why. Let's talk through that. And you have to empower your teams and build those relationships and that rapport and trust to be able to make that happen. So those are all critical steps to a successful CV ASC.
Kristen, I appreciate how thorough that response was too. It sounds like this is just a much more technical area of care that facilities need to be prepared to take on, and that all needs to be developed well in advance. So I appreciate those infrastructure considerations. And Derek, I wanted to bring the conversation back over to you. We've heard a lot already about clinical safety considerations, the infrastructure that's needed. So when you think about all of this, how are you seeing leading organizations effectively re-envision their cardiovascular service lines? Are there particular strategies that you see that are helpful to maintain that alignment with physician partners while also adapting to the new revenue pieces as well?
Sorry, I had to go off mute. Yeah, I think that's a great question, and we see multiple pathways to this working. You see independent providers working very closely and maybe working with a consultant that's done this before or helped develop an ASC in the past or worked with a company like Kristen's that knows how to build these and build the financial metrics that are necessary to make it work. Because Kristen's right, the outlay of cash is huge, and obviously, in most cases, you're amortizing that over time. You have a huge amount of supplies that go into operating an ASC, the different stents and everything else that you have to stock for different size people, and all of this gets very expensive very early. and making sure you're in a position to be able to do that for the long haul while you go through certification and get open, and then that you have the infrastructure behind it to do that well is extremely important. And a lot of the ways we see that happening is partnership with health systems. There are a lot of opportunities for health systems to get in front of this and join with their physician partners in helping develop an outpatient strategy for their cath labs. And we saw health systems, some do this and some not. 10 or so years ago, when we went through the transition to joints in an outpatient center. And some health systems said, hey, this is never going to be the future. They're going to come back, and they kind of ignored it. And in many cases, they lost that business line, or at least greatly reduced it. And it was a huge financial burden to hospitals to lose that because it was a profitable line of business. I think this is even more important in this scenario because not only would they risk losing the diagnostic catheterizations and interventions, they might risk losing their referral source for their open heart program, which is extremely important for the health systems as well. So in joint replacement, a lot of that is definitive treatment and that patient's done and they move on. In this case, you could be losing a double hit on revenue stream by not joining with your physicians and acknowledging where the industry's going and making sure you help them be successful in that outpatient setting. So, there's not one way to accomplish this. All there is something that requires an incredible amount of forethought. A lot of times we see physicians believe that because they have volume, they can accomplish almost anything. And while that's a huge piece of what we need, volume is absolutely necessary. There's a lot of other things that go into this that need to be done right. To go on my background, the revenue cycle for cardiology is incredibly complex. And the differences between office-based lab coding and ASC coding and hospital coding are all extremely different. And you have to be very careful to make sure you're capturing those correctly because payers aren't going to tell you if you're getting it wrong. You're not going to find out until you do an audit and look back 6 months and find out that there was a big problem and a lot of loss there. So there's a lot that has to be done right to make sure that this is a successful venture. And there's a lot of ways to do that, like I said, but making sure that there is a ton of planning that goes into this is extremely important.
Yeah, Derek, thank you so much. And as you were just speaking to all of the forethought that needs to go into this, something that came to mind too is this important piece that I think all three of you have said in one form or another, which is physician engagement and alignment. And so I do want to make sure that we also touch on the concept of physician leadership in this environment of the shift toward outpatient. So Dr. Reiner, I think this would be a great question for you. We're seeing cardiologists grapple with that decision, whether to partner with an existing ASC or start their own, or that hospital physician joint venture situation as well. So how are you seeing physicians evaluate those opportunities? And what do you think makes a partnership model successful from their perspective?
Well, in many ways, this is as important a question as the safety question, because it's at the heart of things. What am I seeing? Lots of different things, and for lots of different reasons. One of the reasons that people are looking, especially physicians looking at this ambulatory surgical setting, is, how would I put it, the politics of evolving physician-hospital relationships in today's environment. And it is, some are looking at options that would say, we're going to bring the hospital employed physicians into this as a partnership with the hospital. Some would say we're seeking an autonomous relationship that we have, so that we own the ambulatory surgical center. That's magnitudes above what Derek just talked about a little bit, for all the reasons he talked about it. And some are saying that, we'll joint venture. And so there are multiple motifs that people are looking at to go into the ambulatory surgical center setting. And it's one of the reasons why, frankly, it's going to be a growing trend. Physicians, if I were to take a snapshot, a good number of physicians are seriously interested in going back into their own business for lots of reasons. No derogatory comments or anything necessary for this. It's just that physicians look like they would like to have more control. This is an environment that they might be able to control and make part of their practice. And so I think you have to navigate those waters carefully. And critical to navigating those waters carefully is assessing the situation that a particular practice may find itself in terms of its relationships, not just with the hospital or the health system, but with others in the community. When you talk sometimes, and when the ambulatory surgical center situations start to evolve, hospitals were quite afraid of this, especially as the high volume, high reimbursement type services would potentially move into another environment. Some physicians were concerned about it for all the reasons we've talked about, and competitors in the environment. Would we miss out if there was a competitor that came in? Would our competing cardiology movement here? All of this said as an entree to say, we need to deal with this, and there are ways of dealing with it. I think this leadership issue and the strategy associated with it is heavily dependent on clinical leadership. A leadership that takes into consideration that the environments in which an ambulatory surgical center is going to function has got to be, in all likelihood, viewed as part of the healthcare system of that community. So it's got, as Kristen has said, and as Derek has said, it's got to be done correctly. Experientially, I'm here to tell you it's not a one and done, one person's idea, and it'll all do well. You need a team with a capital T. And all too often in my talking with physicians, it sometimes revolves around whoever the leader of the practice with, they'll figure it out. And unfortunately, that's not the way it works. You really cannot go into this, and I would say this to anybody who's seriously thinking about it, you need a team of people who are operationally savvy, who can handle the various and sundry components of things. It's not a new statement that physicians sometimes are not great business people. They sometimes don't need to be if they surround themselves with the right people. And to my colleagues who would say, I'm the commander of the ship in the operating room. You are, but you're not. Because no commander of the ship in the operating room does well, and patients don't do as well if they don't have a team of people, from the scrub nurse to the anesthesiologist and to everybody else who knows what they are doing. And I don't, at the head of the table, have to second guess. And it's too complex a business to think that you're going to do it on your own. So leadership is absolutely critical. And my message to the leaders that would pursue this, and to people who have angst about should they come follow this, should they try and get involved in this, you need a strategy. You need a direction in which you're going to go to say, this is what we want to contemplate. Look at the pros and the cons. Every environment has a circle of, if you will, a circle of value. You have your suppliers, your competitors, your complementers, and your people you're going to work with collaboratively. So those four facets have to be looked at very, very carefully and make sure that they fit. And you got to get comfortable with the fact that it is a competitive environment. It's competitive everywhere. Show me a business that doesn't have competitors. How do you work collaboratively? It's an old term. I used to have hair, but it's an old term, but it's applicable. You've got to get comfortable with co-opetition. And I'd say that to my hospital CEO friends and my colleagues who work in medical practices. Stick with who we're taking care of, the people who are seeking our care, and put together the right structures to be able to accommodate them. There's room for plenty. In fact, there's too much plenty in some instances. We don't have enough people to take care of people in the right places. So get comfortable. Leadership critical. And a leadership doesn't have to be around one individual. No one individual has to think that they got to do it all. Surround yourself with people who know what they are doing. It'll work much better. So.
Yeah, love the focus on collaboration and really this human element of what it takes to get physician teams aligned, and from an organizational standpoint as well. Dr. Reiner, really great insights. So I want to thank you for that. And Derek, I think that we may have perhaps I really want to go back to something that you had touched on earlier. You mentioned some unique revenue cycle considerations for cardiovascular procedures in the ASC setting. And so I think kind of drilling down a little bit more on some of those best practices would be really helpful for our leaders. As we're seeing this shift continue, what do you think is most important for ASCs to prioritize when it comes to that financial readiness, also workforce strategy and revenue cycle management to make sure that they're continuing to grow?
Yeah, I think it's a great question, and it's overlooked often because most of this stuff happens in the background outside of the provider's involvement, and they just generally assume it's going to work well and it's pretty straightforward. The difficulty in ASC cardiology care ASCs is there are more of them being built than there are revenue cycle and registration people being trained. So just like there's a shortage of rad techs for the cath lab, there's a shortage of revenue cycle people, specifically coders. The lack of coders that know how to do this work is a huge problem. You generally need a hospital-trained coder that also understands physician billing, and that surprisingly does not exist in today's world in most specialties. It's overlooked how different those two functionalities are, and getting the right person there is going to be important for the next piece that I would say is probably more important, which is registration and prior authorization. So understanding what you're about to do, because in a cath lab, you go in to get a diagnostic cath and possible 17 other things, depending on what they find. So you have to understand the authorization process is different for each payer to know how do you authorize those quote unquote possibles. You're doing a left heart cath, how do you authorize the angioplasty or the stent? Can you, or do they have requirements on the back end for you to get that retro, and are there time limits on that? And in many cases, those time limits are quite frankly prohibitive, but you still have to find a way to follow them. So some payers say, you have to get us the retro auth within 3 hours of the procedure. In some areas we're in, which in my mind, sorry if there's any payer representatives on this call, but in my mind is a technique to avoid payment. But we're functioning within that construct. How are we going to build a process that makes sense for that? And that is, again, collaboration and teamwork. You have to have collaboration between your revenue cycle team, your front desk team, and your clinical team to understand what happened in that cath lab and what needs to be changed on our authorization process so we can get paid for the care that we're providing. It is incredibly important, incredibly difficult to get right, and something that, frankly, physicians haven't had to deal with very often because they don't have those same timelines on their requirements. So when they're the operators, this is new to them, and the general response is to get mad at payers, which is fair, I do too, but they're making the rules right now for better or for worse, and we need to find a way to make sure we get paid by them. Other options exist, but they are long-term options that will fix these problems. In the short term, payment's important. No money, no mission. My dad told me that long ago. And you've got to find a way to work within these unique areas and get paid while you're doing that work. So you need to find good coders that don't always exist. So have training programs for them if you don't. Make sure you have backup for when they may be out. Then you need to make sure you have a good authorization process and you have good communication with your clinical team to understand what happened in that case and that you get it right. And then always have to have a good audit process. You have got to go back and look at that. If you need to use a company to go back and confirm that you're doing well, they're out there. We're one of them. And there are plenty of options to make sure that that work's getting done right. But it is so important to make sure that you're able to keep operating in a positive net income way. So yeah. I know Kristen deals with this often too, so I welcome her thoughts if she's got them.
Well, you didn't say anything that was surprising. You're spot on, right? And it's a challenge. It's a challenge, and having a specialized team, billing and coding team, particularly a coding team, to ensure that they're coding appropriately, and then that communication back to the physicians when maybe things weren't documented, that we're educating one another and making sure that we're putting processes in place to improve upon that every time. And there's tremendous opportunities there. But he used the phrase I use all the time: no money, no mission. And it's absolutely, it starts right here. It starts with RCM. That's big. That's a big deal.
Yeah. Yeah, and in a similar vein, as we're talking through these considerations for ensuring smooth payments, ensuring collaboration, I know folks on the call and probably anybody who's considering entering the ASC space for cardiovascular care is thinking about, well, where does value-based care and risk-based arrangements fit into this equation as well? So Kristen, I'd love to get some more thoughts from you on that specifically. How do you see outpatient cardiology evolving under value-based and risk-sharing models? And what collaboration between hospitals and ASCs and physicians, what do you think that will look like in the years to come?
Yeah, I think that's a great question. And I think it's absolutely going to evolve and continue to evolve, right? The ambulatory surgery space is well positioned for value-based care and bundled payments, right? But we haven't historically as a country done well with value-based care. And part of it is because it's hard. It's really hard. It's hard. It takes a tremendous amount of resources. You need data. You have to be able to demonstrate that you're providing high quality, that you're doing it cost effectively. So those that do it are doing it well and have the resources, but we'll tell you, it's really hard to continue with that. But I think as we continue to mature around software capabilities, as we continue to mature around AI capabilities, I think this just opens the door wide open for being able to provide the data, get the data analytics to be able to differentiate yourselves with your payers, collaboration with the payers, hospitals. I think it's exciting. And I think it opens the door for a great opportunity to really embrace value-based care and to put it into motion in the future without a doubt. And some, again, are doing it today, mostly in the hospital space, but we're certainly, among all of our practices, looking at how can we incorporate that in our operations with our ASCs and our collaborations with not only the hospitals, but our payers and all of our different regions. It's very important, but I think it's exciting and something that we should all embrace and optimize the capabilities and future capabilities to help us be able to provide and demonstrate how we're doing those things.
Yeah, if I may add a little something on that, the value-based care system is definitely here to stay. It's had a rough start getting off the ground. I'll just openly share with you a lot of what I hear. And as I say, it is difficult, and there are reasons why. From a physician's vantage point, it hasn't gotten off the ground as fast as our friends in Washington have felt that it should have. It's particularly challenging to medical practices when you look at bidirectional risk. A medical practice is not an insurance company. And so physicians, as you may imagine, are reluctant to jump into downside risk. Now, they need a team in this again if they go in that direction. The word that I would put out there, if you're representing a medical practice on this, be very, very, very careful about taking downside risk unless you have a team of experts working with you. There are reasons that insurance companies have actuaries. I'll give you an example. Somebody who's got a practice of 100 kids, 18, coming out of college for physical exams is very different than 100 diabetics at age 18. Your downside risks looks a heck of a lot different than the group that's got the diabetics. And so cardiovascular people in general see a lot of older, sicker people, and you've got to know what you're doing in that environment. So if you venture into this, and in all likelihood, you will, if the size of your group and so forth, make sure the things that Derek has spoken to and Kristen has spoken to, that you have people who know what they are doing and can guide a practice through those things, not to the detriment of the practice.
I so appreciate those additional thoughts, Dr. Reiner. And this has just been such a great conversation between the three of you. we're already coming up on about 15 minutes left together, so I want to make sure that we do have some space for audience Q&A. Audience members, the questions that have come through are fantastic. Thank you so much for showing so much engagement and interest in this subject. This is great. So let's go ahead and pivot to sharing some thoughts from the panel on audience questions. And this one is at the top of the queue. So, and this might be a question for Dr. Reiner. It's a bit of a technical clinical question, but it says, if an angioplasty goes south, does the ASC have the capability for an open heart process, or does the patient need to then go to an emergency department to get that addressed?
It's a complicated question, but a good question. Usually the ambulatory surgical centers don't have the capability, in my experience, to do open heart surgery. And this is a consideration to put into the original assessment. Things happen when you're taking care of patients. As a physician, when I'm going to offer a service, I listen to that patient, I make an assessment, and I put the patient candidly in the best place for them, depending on what I've evaluated and what they tell me about their past history. That's step one, not to be avoided. And sometimes we set ourselves up for failure by not taking an adequate history, by not sometimes appreciating the delicacy of the individual in front of us. So you got to be a good clinician up front. The second thing is to say, okay, if this person, even if this person isn't really delicate, you have to ask yourself as an operating physician, what happens if shift happens, S-H-I-F-T, shift happens. And you've got to be, yes, I know, Krista, I'm in trouble. You got to be able to accommodate that. My obligation is to the patient when they come to me. And you almost expect that a patient would ask that question if they've been seriously ill before. And you've got to be able to ask yourself the question, where is the best place for this person to be taken care of? Okay? How many vessels should I dilate? If you look at the data, the morbidity, mortality associated with 2-vessel angioplasty is about the same as 1-vessel angioplasty. But there are those clinical settings, and this is where clinical judgment comes in. And I will back 150% the physician whose clinical judgment is on the line. That is the element of trust that patients will keep coming to you for, is you exercising clinical judgment. I frankly, would not do a complex, high-risk procedure, in rural, whatever state, and expect that patient to be helicoptered 60 minutes away or something like that. I think you're asking for trouble. And that's why, as I say, health systems need to partner together with everybody for the sake of the patient. And that's why there's plenty of work to go around all the way around. But there are things that will happen in the best of hands, unfortunately. And I think you need to be able to be aware of what you do in that event, anticipate a particular problem. And even under the best of circumstances, sometimes things happen, but know what you do when sometimes things happen. There is protocol and workforce that all of the staff need to know how you put it into effect. Krista, you may have some thoughts.
Yeah, I just want to add on to that too, just to put those at ease that maybe don't have an ASC, but you are required from a regulatory standpoint. You have a transfer agreement. It's part of your infrastructure. So your closest hospital, and generally, they're minutes away. And you're right. It starts with patient selection, but you do need to have processes in place by which you would shift the patients out. I love that statement. I'm going to use that going forward. But I do think it's very common, just to put those at ease, that is in place today. It's required from your survey standpoint. They are looking for those types of agreements that you have in place. And then what and how have you trained your teams to be fully aware of the process, because you want to be prepared. And it does happen in your all best intentions. It happens, right? And you want to be prepared to make sure that you can safely and effectively and efficiently get the patient transported to a higher level of care. So just that point. And then the second thing, there's a lot of requirements now from a CMS standpoint, from a reporting standpoint. And then even in some states, there's reporting of any complication rates, any transfer rates, any transfers out to their hospitals or I should say ASCs have to report out on a monthly basis. And then CMS is also requiring, they want to know complications. So we're reporting out quarterly for CMS from a patient experience standpoint, from a transfer standpoint, from a complication standpoint. I think that there's things in place that should put patients' mind at ease, that ensure that you're being looked at, you're being benchmarked. And for now, the requirements from CMS, they're kind of capturing data now, but imagine in a few years, folks in the ASC space will be incentivized or penalized by their performance. So if that gives comfort to people, I hope that it does.
Kristen, let me ask a question. One quick question: do you share those data that you're, on a monthly basis? Is there an operation report that the staff within the ambulatory surgical center sees on a regular basis?
Yeah, I think that that is absolutely happening for sure, and I would say probably love to see it across all of the country, right? And some doing it really well, where they have dashboards present and people know, and they're also doing, if there's a transfer out, they're doing a debrief and doing some things to a root cause analysis to make sure it doesn't happen again. There's some great practices that are happening today, and opportunities, I would say, for some ASCs to make sure that they are collecting that data and reporting it out, not just to their physicians, but to their teams as well.
Right, absolutely. Erica can't hear you. I'm sorry.
Uh-oh, we lost you. Nope.
I don't hear her.
Erica, we're having trouble hearing you, but I bet I can pose one of the questions you got. So we have a question. What procedures would you guys, not me, recommend we start out with if we're looking to start dipping our toe into outpatient cardiac, we'll assume cardiac catheterization, cardiology?
You want to start, Kristen? You want me to start?
Sure. I'll just kind of briefly chime in, but I think, obviously diagnostic casts, peripheral vascular procedures, not complex peripheral vascular procedures, but that's kind of where they started in 2009, if you think about the office-based lab. So I think that's a great opportunity. Device implants such as pacemakers or generator changes are really kind of the great cases to start off with in your ASC.
And I would concur with that. I think one of the things that I would add to what Kristen has said that I found helpful in watching and working in them is to have a team approach, emphasize team. When you start a procedure, make sure that the team knows the key details. There's almost like a huddle before each patient so that you understand what this patient's having and so on and so forth. And as Kristen has pointed out, and in any event that there's a problem, everybody knows the patient quite well. That saves a lot of time, and you need to then make sure people understand that you're doing one vessel, not two vessels, and so on and so forth, right down to whoever is going in and out of the room to circulate and so on and so forth. So I think start small. If you've not had an experience, there's no harm in starting small and having great examples of great experience evolved that you can tout to your patients and to your community in that sense.
Thanks, guys. And I think from my perspective, it's similar to what we see across surgery centers. And even when we see hospitals, when I've seen hospitals opening in my experience, doctor's right. Start small, take little steps and analyze everything you do. So do dry runs, make sure you know exactly what's going to happen if A, B, C, or X occurs during that care, and start with 1, 2 procedures. Often see docs get so excited they want to fill the schedule on day 3 because everything went well on day 1 and 2. Let's not do that. Let's be careful and strategic and make sure everything from the first time you call the patient and they're scheduled till the claim gets paid is analyzed and gone through, and that we are as efficient as possible, and we know where every mistake was made and how we're going to fix it. That's how I've seen centers open efficiently across specialties, is being very diligent and careful with how they move forward. So I will.
Yeah, I think I'll expand on that, just one thing, and it has to do, because I see a lot of questions here regarding cardiac ablations coming in next year. And this also requires a thoughtful process on how you're going to bring these patients in. In fact, you may need to expand your patient exclusion criteria. We're working through that now with our EP physicians all across our organization. But I think it's really important that you're developing a program and that you're making sure that your teams are trained, or you're bringing in EP folks. We're right now doing all of that to make sure that we're proficient, well-trained, comfortable. And then the physician said, hey, you know what? I'm not going to start out, if let's say this proposal goes through, which we all believe it's going to, I'm not going to start out with AFib cases right out the gate. I'm probably going to do some right-sided ablations. I'm going to start off and really get proficient, do these cases. And we have states already doing, from a commercial payer, right-sided ablations. And I applaud you for that, because I know that takes a lot of work, but it's exciting. You're so set up for success to start next year, whereas most ACs are now, it's just kind of opening those gates. But that should be a thoughtful process before you just open up the gates and start doing those procedures. We want to make sure, again, we're providing the highest quality care to our patients, and we're not jeopardizing them, or putting them at risk. So that's just my add-on to that statement.
Thank you. So we'll end on one question, and I think probably each of us has a different perspective on how to answer this, and maybe we'll take a minute or two each. We'll start with Dr. Reiner. What advice would you give to physician leaders hesitant about making the leap to outpatient care?
The advice number one is, this is going to be part of where you take care of patients, especially if you're a doctor who comes to the hospital or does procedures. Even if you don't do procedures, you will be receiving care subsequent to the procedure in an ambulatory surgical center. You need to have a comfort of what's done in the ambulatory surgical center, even if you're not doing it. So get comfortable with the fact this is a trend that's going to stay. It's going to increase, just as people are postulating. It will be something that has to be part of your healthcare community. You will directly or indirectly be interacting with the ambulatory surgical center associated with your health system. Number two, do sit and talk and put together an approach that's methodological and strategic in focus. Explore the ins and outs of this. If you're not conversant with it, talk with colleagues who have done it, access experts to get their opinion. Make sure you set it up right, not just for yourselves, not just for your practice, but for the patients who are going to seek your care, and that you will inevitably be referring some patients to these environments. You have to, as a treating physician, or as a part of a team that's part of a treating physician practice, treating patient practice, you've got to have a comfort that you know what's going on there, that your patients, perhaps your family members, will be treated appropriately in this particular setting. Sort of see over the us and them. That's the final thing. I think all of this has to come back to what I mentioned before. Yes, we all have those four: consumers, competitors, collaborators. But the patient has to drive where you're doing things, and we've got to make accommodations for the fact that we all have requirements to keep our businesses healthy, provide services to our community, right patient, right place, by the right people, anchored appropriately, and build a team that knows what they're doing to assist you in that process.
Thanks, Doc. And I think as I have before, I'll take the business side approach. I think choosing your right partner in this is incredibly important. If that's a hospital venture, if it's another physician group, if it's an existing ASC, or if you're going to do it alone, finding a partner that can help walk you through that process and meet you where you need them is exceedingly important. Companies like ours, or Kristen's, or Dr. Ryan, actually all of ours on here, can help various entities go through this process and do it successfully and do it in a way that means long-term success. Like Doc said, there's competitors to everybody out there. It is worth finding somebody that can assist in this process. It is complex. We're opening a miniature hospital in the most complex area of that miniature hospital. It shouldn't be taken lightly, and finding a partner that can help with that is extremely important. You know, doing your pro forma work, making sure you know how it's going to operate, making sure you understand local regulations. And by the way, we see a lot of questions about local regulations in the chat. We will get those questions, and hopefully we take time to answer each one of you as much as we can, so that you have the answers you need. But finding a partner that can help walk through this process and be there for the short term, long term, or whatever you need in between, I think is integral. And, you know, while maybe a little bit of a shameless plug, it's not because I don't think it's true. I think finding that partner is really, really, really important. So I would end with that. Guys, do you have anything to add as we're bumping up against time here?
Nope.
No, thank you all for your time. Yep.
Nope.
Thanks for having us.
Thanks everybody for joining us. Thanks everybody for joining us.
Thanks, guys. Thank you, everybody that came. Happy Halloween.
Have a great weekend. That's right. Take care.
Bye-bye.